Wow, thank you so much, Dr. Damos. That was amazing. So I think I know everyone here, but yes, I'm Alana, one of the chief residents graduating. And I want to echo what George said last week for his talk. I just want to say I'm really thankful to all the faculty here for all of your teaching over the past 5 years and mentorship. I also want to thank my co-residents for being absolutely amazing over the past 5 years. And especially I want to thank my co-residents who happen to be present in my talk today, which you'll see. So I'm going to be talking about imaging findings and device use for pediatric single-sided deafness. And I first started getting interested in this topic pretty early in residency, seeing how our attendings manage these conversations between patients and families regarding whether or not they are a good candidate for a cochlear implant or not. And I think this is an opportunity to have a really meaningful connection with a lot of our patients, which I really like and is one reason why I'm interested in pediatrics. This particular project came up when I was working with Dr. Ahmad, and she kind of noticed recently over the past few years, as our guidelines for cochlear implantation have changed, so has some of our evaluation and management of those patients, particularly regarding the concept of cochlear nerve deficiency, which a high proportion of our single-sided deafness patients actually have, which affects management. So I'm going to go ahead and get started. So this is an outline for my talk. I'm just going to start with some background. Basically, I'm going to make an argument that 2 ears are better than 1 in terms of speech and language development. And historically, that was actually not always thought to be true. As late as the 1980s and 1990s, it was actually thought that kids who were born with single-sided deafness would likely do just fine in terms of speech and language development. But we have some more recent studies that show that that actually may not be true. Then I'm going to talk about some recent changes in how we manage these patients. In 2019, the FDA approved cochlear implantation for single-sided deafness patients. And this is a press release from that time talking about how MED-EL was the first company that was approved by the FDA for this condition. And so I'm going to talk about how that has kind of shifted our approach to these patients in many ways. And then finally, we'll close with a discussion of who to implant. And I think this is such a key conversation with our patients, deciding who is a good candidate for a cochlear implant or not. These CT and MRI snapshots here are from a patient in our study cohort, a cohort study that I did with Dr. Ahmad and Christy Ward, who's one of our audiologists, and I'll talk more about that a little bit later on. And I have no disclosures. All right, so what is single-sided deafness? It's an asymmetric condition in which a patient has one ear with a severe to profound hearing loss with normal hearing in the contralateral ear. So we're not just talking about a unilateral hearing loss here, which could refer to a mild hearing loss. We're talking about a severe to profound sensory neural hearing loss for these patients. There are many potential etiologies for single-sided deafness in pediatrics patients. This little cartoon here is what cytomegalovirus looks like, and that's one potential cause. Another viral cause is mumps, which is shown here. This CT scan here on the left side shows an incomplete partition. So this is an illustration of how there can be anatomic explanations for single-sided deafness in these patients. And then finally, the CT down below, the MRI down below is showing an example of a patient who potentially has a cochlear nerve deficiency or maybe even an aplastic cochlear nerve, where we're looking at the IAC and we're actually not seeing a normal cochlear nerve present. We'll go through that in a little bit more detail later. However, a significant proportion of these patients actually had idiopathic sensory neural hearing loss, single-sided deafness, which means we actually don't know what the cause of their hearing loss was. Recently, in recent years, we've actually kind of nailed down the causes more specifically, and we'll talk more about that. I think fewer and fewer patients now are being called idiopathic in terms of their single-sided deafness. The picture in the middle of the screen shows an anonymous cute baby who was born at Lucille Packard a few weeks ago. And this baby's picture was used with permission. I actually have a lot of pictures of babies in my talk, and just so you know, they were all used with permission from the parents for this talk. But this is a picture of this baby who got a newborn hearing screen at hour 8 of her life. And the way we do newborn hearing screens here at Lucille Packard is with an automated ABR. And it's actually a great test because you can actually test each ear separately in automated ABR. So conceivably, you could pick up on a single-sided deafness in a patient at hour 8 of their life, put in a referral to otolaryngology and audiology, and get a workup. Typically, what we do for these patients, at least at Lucille Packard, is we want to get a diagnostic ABR for them by the time they're around 6 months of age, and then hopefully start treatment by around that time. After 6 months of age, we rely more on some behavioral testing for these patients typically. However, by the time someone is 5 or 6 years old, we can do conventional audiometry for them. That's the audiogram shown on the right side of the screen. This is a patient in our study cohort who has a right-sided single-sided deafness. So that's denoted by the blue line, which shows a profound hearing loss. And then that's compared to that's shown by the red line, which shows the profound hearing loss. And then the blue line is the normal hearing in the left ear. All right, so why does this matter? I think it's pretty intuitive probably for everyone here that someone with a bilateral severe to profound hearing loss would have trouble with speech and language development. But why does it matter when someone has one working ear and one ear with a severe to profound hearing loss? There are actually three main concepts here to talk about. The first is difficulty understanding speech and noise. The second is non-auditory deficits like cognitive fatigue, academic deficits. And finally, these patients experience some unique challenges that can lead to delays in treatment. And I'll just say again, like historically, even through the 1980s and into the 1990s, we actually kind of had the approach sometimes of reassuring patients and families that their child would likely do just fine in terms of speech and language development. Maybe have them come back once a year for routine hearing tests and to make sure that the contralateral side was still intact. But at least from my understanding, at around that time, we really weren't typically treating these patients for their single-sided deafness the way that we do today. So I'm going to go through these things one by one. So let's start with difficulty understanding speech and noise. So this is another anonymous cute baby. This baby has normal hearing, but let's just pretend that the baby has a single-sided deafness. What challenge might they have in understanding speech and noise? And I think it's a little bit intuitive here too. So say this baby is kind of one-on-one with mom, they're in a quiet environment, mom's talking to the baby. It's probably going to be a little bit easier for the baby to understand speech compared to if the baby was at a dinner party with mom and mom's friends with a lot of background noise. That may make it more difficult for the baby to filter out speech and noise. And that's a challenge faced by these pediatric single-sided deafness patients. And that also applies, of course, to school and other potentially noisy environments that these patients encounter. The concept of assessing speech and noise is actually becoming more and more important in audiology in recent years. Dr. Matt Fitzgerald, who's here at Stanford, has actually done a lot of work showing that speech and noise assessments are actually really relevant clinically, and especially compared to pure tone audiometry in many cases. And I think we're finding out more and more through Dr. Fitzgerald's work that the ability to understand speech and noise is actually really important for these patients as well. And I think as our understanding of assessing speech and noise has developed, so has our understanding of single-sided deafness. And these things kind of go hand in hand, at least in my mind. Not only do these patients have trouble understanding speech and noise, but that actually leads to additional difficulties related to greater listening effort and cognitive fatigue. So I think it's really important, especially like for children who are already under a high cognitive load processing the world around them. The last thing we want is for them to kind of be diverting a lot of attention to simply trying to understand speech in the world around them. And cognitive fatigue in children can lead to changes to how they socialize and increased irritability and behavioral problems. So I just want to say, though, that this challenge doesn't happen to every child, every single child with single-sided deafness, but certainly a lot of them. Okay. These patients also experience some non-auditory deficits. So these are a few examples of papers that came out like the mid-80s and into the 90s that showed some new concepts related to how these patients experience the world around them. And overall, the idea here is that there are some academic deficits experienced by them. One of these papers showed that pediatric unilateral hearing loss patients are actually 10 times more likely to be held back a grade compared to their normal hearing counterparts, which sounds pretty significant to me. They've also shown that these patients have higher levels of stress and lower self-esteem compared to their normal hearing counterparts, which of course plays a big role. One potential criticism to these papers, though, is that they're kind of underpowered. They were in small study cohorts. The studies were done in kind of a new and developing field. I think it was probably pretty challenging to research these patients back then. But even though it's difficult to draw broad conclusions from these few studies, I think probably what we can say is that there are at least some children who experience these non-auditory deficits, and ideally no children would experience those deficits. Furthermore, though, these studies were actually validated and supported by more recent studies. So this is a paper that came out in 2010 by Dr. Liu at the Washington University in St. Louis. And she did a case control study comparing 74 cases of children with unilateral hearing loss to their siblings who had normal hearing. So presumably the siblings grew up in the same environment and were exposed to all of the same factors that lead to language development. And then she just tested them for their speech and language development skills. And she found that the cases actually across all three metrics, listening comprehension, oral expression, and oral composite scores actually showed lower scores compared to their normal hearing siblings. And then I didn't show this in the slide, but the paper also has this really nice like multivariate linear regression that controls for the effects of other potential independent predictors of speech and language difficulty. And even in that analysis, single-sided unilateral hearing loss was shown to have a significant impact on language development. So overall, just taking this globally, I do think that it's true that pediatric patients with unilateral hearing loss, and even more specifically with single-sided deafness, probably do have some challenges in terms of speech and language development. All right, so what about delays in treatment? So we do know that pediatric single-sided deafness does tend to be diagnosed relatively later compared to bilateral single-sided deafness. Furthermore, these patients are more likely to experience delays in treatment. And one of the reasons for that is that there's so much variability from state to state over whether treatment for this condition is even covered or not. So there are kids who are diagnosed and then never treated. And the reason this matters is because even though the human cochlea is functional at birth, the auditory system is still immature. And we know that it undergoes a lot of developmental changes up until around 3.5 years of life. And we do know that we need to stimulate the auditory system in order for it to undergo conventional development. That's really important to capitalize on that in the first 3.5 years of life. So this slide here shows a graph from a study that illustrates that point. This is a study from way back in 2005. And what this shows is P1 latency as a function of age. So I'll go through what that means. So P1 is the first peak in an ABR, and the latency is the period between the stimulus being delivered and the peak appearing. And it's been well validated in the literature that the P1 latency tends to be a good marker for maturation of the central auditory pathways. So in this graph here, the two solid lines are the normal range for P1 latency according to age. They're 95% confidence intervals. And so you would say that a normal P1 latency according to age should fall between those two solid lines. In this study, they looked at a group of early implanted children who were implanted before 3.5 years of life and compared them to late implanted children who got their cochlear implants 7 years of life or later. Each line in this graph is one patient, and each dot on the line is a different time point where their P1 latency was tested. So the dots that are earlier in time are the time of cochlear implant activation, and then a dot later on down the line is a certain time period later that they were testing. What you can see is that over time, the early implanted children are reaching normal P1 latency, or close to normal P1 latency, whereas the children who are implanted later really don't reach a normal P1 latency. So just to summarize from this, it does look like there is an effect of early implantation on P1 latency, which is a marker of central auditory pathway maturation. It seems to be dependent on age. And that's true actually not just in ABRs, but in numerous clinical studies that have shown that language development is actually critical in the first few years of life, and that earlier implanted children tend to do better in terms of speech and language development clinically. So we have electrophysiologic data and clinical outcomes that show that early implantation is better for these patients. And I think it's especially relevant for single-sided deafness patients because of the delay in treatment that they tend to experience. Okay, so why does all this happen? Like, why do pediatric single-sided deafness patients experience all these challenges? So I'm going to talk about the binaural advantage here, which is just the advantage of having two functioning ears. And we're going to pretend that this cute anonymous baby has a single-sided deafness, which he doesn't. He has normal hearing, but we'll pretend. And basically, if we were to treat his single-sided deafness, our goals would be to try to restore the binaural advantage. That would be an ideal treatment. And what that refers to is eliminating head shadow, preserving squelch, preserving sound localization, and preserving binaural summation. I'm going to go through those one by one. All right, so let's talk about the head shadow effect. So all this really refers to is the fact that if a sound is coming towards the head from one side, it's going to be perceived at higher decibels than the sound in than the perception of the opposite ear. And at lower frequencies, that difference tends to be just around 6 decibels, 6 or 7 decibels or so. So like say a kind of a low frequency sound is coming here to my right ear, my left ear is going to perceive it about to be 6 decibels quieter than my right ear. That's actually really helpful for someone who has 2 working ears, but for someone who only has 1 working ear, that can be a huge problem. And that actually can impact speech recognition. So let's say speech is delivered to the worse hearing ear, but noise is directed to the better hearing ear. The speech signal is going to be attenuated, but the noise signal is not going to be attenuated to the better hearing ear. That's going to lead to a lot of trouble understanding that speech. Okay. Next slide. So squelch. So what is squelch? This just refers to the ability of our central auditory pathways to filter out background noise from the noise that we really want to hear and understand. And it takes 2 working ears in order to be able to do that. So let's see, for example, let's say Michael Belsky's like talking to me. Basically, this is just meaningless noise, right? Coming towards me. But then let's say, well, Lacey's talking at the same time, and I really want to hear what Lacey's saying. They're both talking at the same time. Because I have 2 functioning ears, I can filter out the meaningless noise from and I can hear what Lacey says, and I can focus on that. And that's basically what squelch is. And you actually need 2 working ears to be sending signals in the central auditory pathway in order to be able to do that. Okay, next is localization of sound. This is actually pretty intuitive. So this just means that because our 2 different ears experience sounds relatively at different time intervals and levels, we can actually localize sound with our 2 working ears in a horizontal plane. And then finally, binaural summation. I think this is also pretty intuitive. All this means is that if a sound is coming to 2 working ears, that sound is perceived as slightly louder than if the same sound was coming to just 1 working ear. And I think the classic teaching, from what I can tell, is the difference is usually around 3 decibels between binaural hearing and monaural hearing. Okay, so far in the talk, I've described our understanding of single-sided deafness and why it matters. And so now I'm going to talk more about what we actually do for these patients. So we'll transition to management. This is the same audiogram that we looked at earlier, and it's from our study cohort. This shows a patient who has a right-sided single-sided deafness. And the recommendations shown here are just a screenshot taken directly from this patient's chart. Basically, you can see that we want the patient to return in about a year for another evaluation. And we've recommended some interventions that this patient get at school, like an individualized education plan, an FM system, preferential seating in the classroom, and so on. A lot of really good evidence-based interventions for this patient. I'm going to talk in a second about what sort of device we might recommend for this patient. But first, I want to make a little side note. So this is actually my dad. My dad has really bad hearing. My whole life, he's had a lot of trouble hearing, and that's related to some recurrent untreated infections in childhood. But basically, like, one of my strongest memories of him is that he's always holding a hand up to one ear, and one of his ears is worse than the other. And I think this is interesting because that's the sort of adaptive mechanism that a lot of single-sided deafness patients will actually use and have learned to use in their daily lives. And there are other adaptive strategies that these patients use, like, for example, maybe always trying to sit on one side of the classroom so that their better hearing ear can hear what the speaker's saying, or walking on one side of a person, like when they're walking down a hallway, for example. You know, ideally, though, what we would have for these patients is a good intervention so that they don't have to do all those adaptive mechanisms in their day-to-day life. So let's talk about some devices that we might recommend for these patients. The panel on the left shows our conventional air conduction hearing aids. There's a lot of options for these: receiver and canal, in the ear, in the canal. Conventional air conduction hearing aids tend to work well for patients who have maybe a mild to moderate hearing loss. Probably not well, though, for a single-sided deafness patient who has a severe to profound hearing loss, just because they're not able to provide really enough of a boost for that ear to be able to hear those sounds coming in. So probably we wouldn't recommend a conventional hearing aid for a pediatric single-sided deafness patient. And in every case, I'll say. The next option is contralateral routing of sound. This is our cross devices. For cross devices, there's a microphone placed on the worst hearing ear that transmits sound over to the better hearing ear. So the better hearing ear is still the one that's getting the sound stimulation. So that does overcome some things, like it does help the patient be able to perceive sounds all around them, but it doesn't really help with sound localization. And it can actually make speech recognition and noise worse, because if you have noise on the side of the microphone and someone's speaking to you in your better ear, that noise is going to be amplified and sent over to your better hearing ear, which is going to make it harder to filter out the speech from that noise. On the top right are our bone conduction devices, and we use these all the time. I think we probably all know about these. There's the softband Baha, the bone conduction or the bone anchored hearing aid, and the Ossia, which is a newer magnetic option. The bone conduction devices actually have been shown to have the best outcomes for pediatric single-sided deafness patients in a lot of cases. This allows the patients to filter out speech and noise better, and also has shown improvements to quality of life. And we'll commonly recommend these sorts of devices for our patients. Overall, though, even though all these devices have pros and cons, there really is no conventional amplification device that will boost the hearing enough for someone with profound hearing loss in order for them to take advantage of binaural hearing. And so that's really what we're aiming for. And that brings us to cochlear implants. That's the only option with the potential to really restore binaural hearing and all the advantages that come along with it. All right, so I'll talk a little bit about some data related to device use for these patients. So this is from a study that I worked on with Christy Ward over in audiology, and Dr. Ahmad, as well as some of our other pediatric otolaryngologists who do a lot of otology work. And we just wanted to look at the device use for a cohort of pediatric single-sided deafness patients. We have a cohort of 190 patients who are referred to Lucille Packard with single-sided deafness. And we looked at their device use according to data logging, which is the devices themselves actually record how much they're being used. And so the rightmost column there shows the average device wear time in terms of hours per day. When I first saw this data, I was honestly really surprised by how little these patients are using their devices. So for the bone conduction hearing devices, the average wear time was only 1.8 hours per day, which is actually very little. Like school is much longer than that, right? So, but they're only using their devices an average of 1.8 hours. Cross devices, which a lot of our patients had, 3.2 hours. Some patients had conventional hearing aids that were used around an average of 1.6 hours. And then we have five patients in our cohort who had cochlear implants who actually used their devices a little over 5 hours per day on average. I think that's actually really encouraging. It seems like our patients with cochlear implants and single-sided deafness are actually using their devices. This was a pretty small study, but that result showing high device use for cochlear implantation in these patients has also been supported by some subsequent studies that I will mention. All right, so just to recap, there are some unique challenges facing pediatric single-sided deafness patients, ranging from potential speech and language problems, difficulty understanding speech and noise, delays in treatment, as well as some unique challenges to actually finding a good device for these patients. Let's talk about what people have been doing more recently now. So this is that press release that I showed earlier talking about how the FDA approved these devices for pediatric single-sided deafness patients, not just pediatrics, but actually adults as well, in 2019. And after this guideline, or after this FDA approval came out, there has been this shift in how these patients are evaluated and managed. So Dr. Ahmad actually had noticed that there are more and more patients with pediatric single-sided deafness being referred to clinic, asking if they might be a good candidate for a cochlear implant. Many of these patients actually didn't have any imaging coming into the clinic appointment. And so the understanding of their anatomy actually wasn't there yet at the time of their initial evaluation. And then as part of the workup for cochlear implantation, of course, we get an MRI. And those MRIs at times showed cochlear nerve deficiency. And so we really wanted to look at the prevalence of cochlear nerve deficiency for these patients, because that does really impact the decision made to proceed with cochlear implantation or not. And I'm just going to talk about why that is really quick. This is just a quick schematic of what a cochlear implant is and how it works. There's a microphone located externally. That microphone sends sound to the speech processor, which encodes it into an electrical signal. That's then sent via the transmitter to the internal receiver, which sends the signal via the electrode into the cochlea, where it's picked up by the cochlear nerve, also called the auditory nerve. So in order for a cochlear implant to work, we obviously need a functioning cochlear nerve. Otherwise, how will the signal even get to the brain? That's the idea here. So let's talk about cochlear nerve deficiency. And we'd use the term deficiency here instead of aplasia or hypoplasia, just to say we're not really saying anything about causality here. All we're saying is that the cochlear nerve is smaller than usual or than a normal nerve, or maybe even absent. This is a nice couple of pictures from a textbook about pediatric cochlear implantation. I'll just talk about these really quickly. So panel A up top shows a CT temporal bone. The white arrow is pointing at the internal auditory canal that's normal in caliber. And then the black arrow is pointing to the bony cochlear nerve canal, which is simply the bony canal where the cochlear nerve leaves the IAC to go into the cochlea. So that image shows normal anatomy, normal cochlear. What we can infer is that there is likely a cochlear nerve present, although obviously we can't say one way or the other on CT scan for sure. Panel B shows a stenotic IAC. So you can see compared to panel A, the IAC is very narrow. Of course, we can't see the nerve or not clearly on CT scan, but we might make an inference here about the presence or at least the size of the cochlear nerve. And then panel C actually shows the bony cochlear nerve canal fully covered by bone, not patent. So another inference we can make from CT scan is it's possible this patient doesn't have a cochlear nerve, or if so, maybe it's just really small. MRI, though, obviously gives us a much better look at the nerves themselves. So looking at the bottom, panel A, which is an MRI, this shows our classic cross-section of the IAC, which it comes up every year, I think, on the in-service, maybe on boards too. But the small white arrow shows the facial nerve. And then below that, the larger white arrow shows the cochlear nerve. And then, so that's normal. And then panel B shows that the facial nerve is present, but you can't really clearly see the cochlear nerve in panel B. Maybe it's really small, or maybe it actually is absent. So that's just the concept that we are talking about here. The reason that this was interesting for us to look at was because in previous literature, the report of the reported prevalence of a cochlear nerve deficiency ranged between 18 and 55%. Anecdotally, we thought maybe it might be higher. So we just wanted to take a look at that. So we looked at the prevalence of cochlear nerve deficiency in our cohort of pediatric single-sided deafness patients. This was our 190 patients. And then I just wanted to show a couple example images from our study cohort. So the image in the middle of the screen is a CT temporal bone. Sorry, it's kind of blurry. The purple arrow is pointing towards the bony cochlear nerve canal, which does not look patent in this patient. And then the panel on the right is the MRI for that same ear that shows that in the IAC, where we would expect the cochlear nerve to be present, we don't really see it clearly. So that's an example of how we might diagnose a patient in our study with a cochlear nerve deficiency, at least radiographically. And what we found was that out of our 190 patients, 112 of them had a cochlear nerve deficiency radiographically. That's around 58.9%. And interestingly, not all those patients had MRI, but for those who did have MRI, the rate ranged somewhere between 63 and 76%. Of course, I think we would expect MRI to be a little bit more sensitive than CT for detecting a cochlear nerve deficiency. So I think all of this makes sense. Basically, what I'm saying here is that the rate of cochlear nerve deficiency that we observed here was on the higher range of what was previously reported. And I think probably now that more and more of these patients are actually getting MRIs as a result of their cochlear nerve evaluation, probably we're just kind of discovering the true rate of cochlear nerve deficiency, whereas in the past, we didn't really know. Okay. All right, so just to summarize, so far in the talk, we have talked about why single-sided deafness matters, and we've discussed what cochlear nerve deficiency is and how nowadays we think probably at least around half of pediatric single-sided deafness patients have a radiographic cochlear nerve deficiency. So let's move on to the next section of the talk. And this is, how does this affect our counseling of a family who comes to clinic with a baby with single-sided deafness? So let's just pretend this anonymous lady was diagnosed with single-sided deafness. She wasn't, but let's pretend. And what are we going to tell her family? Okay, so the big question here is who to implant. And I think this is probably like the most interesting topic that I have to talk about today, because this is really controversial right now in our field. When I was on the interview trail last year for fellowship, this topic actually came up a lot, and I realized there's such a wide variety in how surgeons are addressing this right now in our field. So I think it's really exciting to look at. The big question here is who does well with cochlear implantation, and can we predict that? I wanted to show this screenshot here of some guidelines that came out in 2022, because I think this shows one extreme viewpoint of how these patients should be treated. So this is from the American Cochlear Implant Alliance Task Force. And they put out guidelines looking at the assessment and management of cochlear implantation in children with single-sided deafness. Guideline number 1 was that cochlear implantation to address single-sided deafness in an ear with cochlear nerve deficiency is contraindicated. So this is really strong language. I think whenever we as surgeons hear the term contraindicated, like that's actually like very firm language. And they go on to say that accurate diagnosis of nerve deficiency is important because it's present in almost half of children with single-sided deafness. Therefore, they recommend high-resolution MRI of the IAC. I just wanted to show this as an example. People are actually implanting these patients, which I'll talk about. Like, even though this guideline says it's contraindicated, even before the guideline came out, these kids were getting implanted. So I want to talk about that too. So what are the outcomes of implanting an ear with a cochlear nerve deficiency? There are a few studies that have come out on this topic. The first one I talk about is by Buckman, which was published in 2011, actually. And they actually had 21 cases of cochlear nerve deficiency, and they compared those cases to 55 patients who had other cochlear anomalies or inner ear anomalies, like enlarged vestibular aqueduct. These patients were all implanted. They did find that the children who had cochlear nerve deficiency were less likely to achieve open set test speech perception, which is actually, I think, really critical, because kind of our argument for implantation is that it actually helps with speech and language development. One thing to note about this study is that all of their patients with single-sided deafness and cochlear nerve deficiency were implanted at 5 years of age or later, which is probably outside the time window of capitalizing on central auditory development. They also found that almost all of these cochlear nerve deficient patients used some visual supplementation to help them communicate. And furthermore, this wasn't just shown clinically, but also electrophysiologically with this different author, Valero. This was published in 2012. They had 7 cases of cochlear nerve deficiency, 19 controls. All of these patients got cochlear implants, and they actually found that the ABRs after cochlear implantation were abnormal in the cochlear nerve deficient patients. This makes sense anatomically, right? If your cochlear nerve is not normal, how could it send a normal wave? Or how can it send a normal signal to the brain? So overall, I think it kind of does make sense when you think about it, that we're getting abnormal results after implanting these patients. This is the flip side. So there have been a couple studies that have shown some optimism in terms of implanting these patients. The first one I'll mention is Warren, published in 2010. And this group implanted 3 pediatric patients with cochlear nerve deficiency. These patients actually all were said to have an absent cochlear nerve on MRI, but did have some electrophysiologic evidence that there might be some nerve fibers present in the canal that might be functional. These patients actually did use their cochlear implant after, or 2 of the 3 patients actually did end up using their cochlear implant. And all of the patients did show some responses to auditory stimuli after implantation, and their parents and teachers subjectively felt like they benefited from the implant. The point I want to make here is that I think all this is saying is that MRI is not 100% sensitive for detecting the cochlear nerve. I think it's possible that there might be just a few nerve fibers that we aren't able to see on MRI that are still firing for these patients. The other thing about this study was that these were 3 very highly motivated families who were providing a lot of auditory stimulation in the ear that had profound hearing loss, and were very motivated to do all the rehab after the cochlear implant was placed. The next study is by Young, looking at 10 patients with cochlear nerve deficiency that got cochlear implants. 3 of them actually ended up developing open set speech perception skills, and another one developed closed set speech perception. So that's 4 out of 10 patients who it seems like may have some positive results in terms of their speech and language skills. Both authors for these papers do point out that the imaging findings that were obtained preoperatively, the MRI findings, actually did not predict post-implantation auditory performance, which I think just goes to show, like, we can't pick up everything on imaging. It's not 100% sensitive. Just regarding cochlear nerve deficiency, though, there are overall pretty good outcomes for implanting single-sided deafness patients as a whole. So there have been a couple different pretty well-designed studies. For this, one is this congenital unilateral hearing loss trial, which had 20 patients with single-sided deafness who were implanted. A couple other papers as well that showed improvement in open set speech perception and speech understanding and background noise, with no evidence of interference between the implant and the good ear. Another author showed that these patients actually did benefit a little bit from the binaural advantage after implantation. They had better sound localization, improved quality of life. And finally, they actually were using their implants 6 hours per day on average or more, which I think may show that they actually are benefiting from getting an implant. And then one person, Patro, did look at complications. The only complication in a group of 19 single-sided deafness patients who got CIs was a little bit of bleeding from the surgical site that did not require going back to the OR to manage. That fits with our understanding of cochlear implantation, which is that we think it's a pretty safe surgery overall. And then let's say you decide to implant one of these patients. When should you do it? I would make an argument that you want to implant them as early as is safely possible. We know that the longer we wait, the more likely there are to be poor speech and language outcomes. One study by Hoff looked at 219 children who were implanted before 3 years of age, and made an argument that it was safe for those patients to be implanted. The other factor here is that a lot of kids with single-sided deafness have factors that puts their other ear at risk, like a history of a CMV infection or cochlear malformation. So you might want to consider implanting the worst ear earlier before the other ear also experiences some decrease in hearing. And then I think this is my last slide, just some quick clinical recommendations and future directions. So overall, I think it is true that our pediatric patients with single-sided deafness have a high prevalence of cochlear nerve deficiency. I think it's probably somewhere around 50–55%. And that should inform counseling of these patients and families. There are some surgeons who would actually consider putting a cochlear implant in a patient who has a radiographic cochlear nerve deficiency, and there are some who wouldn't, and I think it's very individual. It also depends a lot on the patient and the family and how motivated they are to try the implant, even knowing that it may not necessarily lead to improved speech perception. I'd recommend doing MRI early in the cochlear implantation workup, just because it can be devastating for families to come to clinic expecting to be told they might be a good candidate for an implant, only to be told a few weeks later after they get their MRI that they don't have the right anatomy for it. But I do think that even if the MRI does not show a nerve, you could consider getting an ABR or another electrophysiologic study just to see if there are a few nerve fibers if the family is very highly motivated to proceed with cochlear implantation workup. One thing I really like about pediatrics is the counseling and the team-based approach. I think it's really fun and really educational to get to work with experts like audiologists, speech language therapists. Being part of a team like that who has different training than me, I think is like so meaningful and so valuable. And here at Stanford, we have a cochlear implant conference where every single patient who's being considered for an implant is discussed with all these experts. And I think that's really necessary to make the right decision for our patients. And then my final point is that there are probably a few children out there with a cochlear nerve deficiency who achieve open set speech. But even for those who don't, there might be other benefits to implantation like in terms of sound localization or sound perception. And that's all. So I want to say thank you to Dr. Ahmad, my mentor, Christy Ward, our audiologist, the rest of the pediatric otologic team. Lacey Nelson is continuing work on this project. And then we have a medical student, Sai, who's presenting part of this at Academy in October. So try to check it out if you can.
That's all I've got.